So thank you for joining. I'm going to talk about very early onset IBD. So first, just to go through, I have no financial disclosures. And so just to highlight the objectives, so defining what is very early onset IBD, summarize the workup, which I think is probably the most important part of this talk, is what's involved in diagnosing very early onset IBD, and then just going through some examples of monogenic causes of IBD. So just to get started on some definitions, so very early onset IBD is those that present less than 6 years of age. Um, it is further then classified into infantile onset IBD when presenting less than 2 years of age, and then neonatal onset less than 27 days. And so I think sometimes people don't realize that it can present at these young ages. So just keeping that in the differential, and this incidence is unfortunately rising as well. And so what is unique about VEO-IBD? So often when they present, they're more severe presentation and often more difficult to treat with our conventional therapies. They often have pancolitis, about 40%, and more likely to be diagnosed actually with IBD undifferentiated. This phenotype can change over time to declare itself as being more Crohn's or versus ulcerative colitis, having extension into the small bowel or finding of granulomas. And this becomes more relevant when there are surgical discussions from a Crohn's versus ulcerative colitis standpoint. So it's just important to keep that in mind. And then just to kind of know why we want to highlight this group specifically is because in this age group, even though it's not a large population of those with IBD, in the pediatric patient population, about 6 to 15% of those are diagnosed less than 6. And a smaller portion of those can have that monogenic cause. So when I'm talking to families about doing this very early onset IBD workup, looking for a monogenic cause, I discuss that in all likelihood we won't find a monogenic cause, but in that portion that we do, that 15 to 20%, it can influence the therapy that we start or the monitoring. So it's important to do those evaluations to look for that. And so why is this incidence rising? It's thought that it's a combination of how the gut microbiome acts with the immune system, because these are both being developed in that birth to 3 years of age time frame, and often that coincides with the onset of disease. So when some sort of disruption happens in either of these systems, it can lead to disease. So things that are identified include route of delivery, vaginal versus C-section, gestational age, maternal diet, such as a Mediterranean diet can be somewhat protective, and then infant feeding formula versus breast milk. And when someone comes into your office and there's concern for very early onset IBD, it's important to do a thorough history. So things to specifically ask about, or when the symptoms started, is there bloody diarrhea, any vomiting, skin changes like folliculitis and dermatitis, significant infections, other autoimmune type of things going on, perianal disease, issues with growth, failure to thrive, and kind of unexplained fevers. And then going through the family history, specifically asking about consanguinity, immunodeficiencies, autoimmunity, HLH, arthritis, increased infections in the family, any other family members with IBD, malignancy, atopy, and X-linked diseases. And then when you move on to your physical exam, specifically looking for rashes like the erythema nodosa, pyoderma gangrenosum that we're familiar with on the adult side as well, of course, perianal lesions, oral lesions, arthritis, splenomegaly, and adenopathy. And so after those initial evaluations, if there's concern for IBD, you want to move on to do some testing. So pretty typical initial testing that's done compared to the other, workup that's done for a concern for IBD. But when you do the initial screening labs, there are some things that might stand out. So with the CBC, obviously, commonly we think of like anemia or low platelets, but you can also see some signals that might indicate a monogenic cause by looking at anything kind of like suggestive of defects in the neutrophils with like signs of neutropenia, etc. And then if the ESR and CRP are like extremely elevated, that could be also a sign of a hyperinflammatory defect. And then, doing the CMP, we often will look for like the albumin being low. Calprotectin and lactoferrin can be helpful, as well as fecal occult blood. And then depending on the clinical presentation, you might consider doing a celiac and thyroid screen. And then doing your infectious stool studies as always. So just one thing to note though, in this population, the C. diff cannot always be reliable in those less than a year because it can just be colonized. So just something to keep in mind if that testing is done. The other thing to keep in mind when doing this evaluation, it isn't unreasonable to trial 2 weeks of an elemental formula in those less than 12 months of age to see if it maybe is more of a milk protein intolerance going on while these other evaluations are being done. So kind of moving on from that initial evaluation in the exam room and the initial testing, if there's suggestion and concern for IBD, we move forward with the diagnostic testing. So the typical testing that we always do with EGD and colonoscopy with ileal intubation, but the biopsies might give you some insight if there is a monogenic cause. So specifically like the apoptosis could be a clue for an underlying genetic defect, villus atrophy, and then could indicate like a lymphocytic infiltration. And then, for example, chronic granulomatous disease could be indicated by granulomas being on the pathology. And then, of course, we always do our small bowel imaging with CTE, MRE, or intestinal ultrasound. So typical workup there. And then if we, kind of find that this is IBD based on that testing, we move on to kind of more the specific VEO-IBD testing. First, doing immunology testing, looking for, immunoglobulins, things that might signal a monogenic cause there with like IgA deficiency, lymphocytic subsets, antibodies to the vaccines to see if there's, that memory's developing, and then the neutrophil oxidative burst assay to look for chronic granulomatous disease. So most of this testing, it depends on, I think, the institution, but we might do some of this preliminary testing as the GI team, but sometimes also depending, the allergy immunology colleagues might also, we might consult them to do some of this testing, but often we'll at least start that. So when they meet with them, that's already completed. But just to kind of know that kind of once you get kind of that suggestion or confirmation that it is very early onset IBD, we usually involve our colleagues in different subspecialties. So we include allergy immunology to help with this interpretation for sure, but we might order those additional labs just to have those ready for further evaluation. And I think the other thing to note with this is that this testing is ideal to be done before therapy is started because, as you all are well aware, a lot of our treatments affect the immune system, and that can affect these results. So even just something to think about. I think more recently I've seen several teenagers and young adults that were diagnosed in that very early onset time frame, and they never had any of that testing done because it wasn't routine at the time. And so trying to go back and do some of this evaluation just to make sure we're not missing something if someone's had more of a rougher course, it can be a little hard to interpret. And so again, kind of moving on with that additional evaluation. So we do the immunology workup and then also include our genetic colleagues to do some of the sequencing. And so we generally always do the targeted sequencing panels to look for primary immunodeficiencies. And then if there is nothing revealed on those testing, then we would move on to whole exome or whole genome if there is a really high suspicion, just to kind of help perhaps determine next steps as far as treatment goes and monitoring. Okay, so moving on from that, I was going to kind of just go through briefly some of the more common monogenic causes just to kind of get familiarity with them. So they can impact general immune dysregulation, T and B cell defects, phagocytic defects, hyper and autoinflammatory conditions, epithelial barrier dysfunction, and then kind of like a broader category of other. So some examples of the adaptive immunity defects include IL-10 deficiency. So this was actually the first gene identified as causative for VEO-IBD, so kind of one to note. And IL-10 is an anti-inflammatory cytokine, so symptoms that could be suggestive of this include severe colitis, folliculitis, arthritis, and perianal disease. And with this one, there's also some monitoring that would go along with this, including looking for increased risk of lymphoma and large B-cell lymphoma. So not only does it, there's a potential influence on treatment here, but also future monitoring. So the treatment is hepatopoietic stem cell transplant, and the amazing thing is likely curative. And so, especially given what we talked about before, with their presentation often being more severe, often there's surgical discussions earlier on. And so if these defects aren't identified, the patient could have maybe gone to surgery and they maybe could have, had this cured by doing the stem cell transplant. So just to kind of emphasize why these evaluations are important. And so next, another one to think about is Wiskott-Aldrich syndrome. So this one affects the B and T cell responses, and their effect are essentially ineffective. It's X-linked. And the symptoms there could be thrombocytopenia, eczema, recurrent infections, and then that exclusive colonic disease. Again, there's that risk for lymphoma and associated with other autoimmune diseases, so something to keep in mind there if that's identified. And then the treatment is hematopoietic stem cell transplant, again, which is likely curative. So you'll see this common theme here with the different treatments once the defect is identified. And so to go on to chronic granulomatous disease, which is a phagocytic defect. So this defect affects the intestinal phagocytes that kill and clear bacteria. And this is probably one of the more common forms of VEO-IBD, so much so that we actually, if anyone has even a diagnosis with granulomas on their biopsies, even if they're not in the VEO category, we generally do that chronic look for chronic granulomatous disease using that neutrophil oxidative burst assay, specifically because, as we talk about below, the treatment with an anti-TNF is contraindicated, which is something we use quite commonly in pediatrics. And so that would be something we want to make sure we're not missing, because it could set the patient up for really poor outcomes if that's missed. And so with chronic granulomatous disease, again, similarly, symptoms include frequent infections, intestinal inflammation, obviously, and then other associated autoimmune diseases. Treatment can be, again, curative once this is identified. So important to identify. Moving on to the regulatory T cell defects, they include things like IPEX, which is more commonly known. So the presentation is very early, so onset near birth, and they can have diarrhea with or without blood, psoriaform dermatitis, alopecia, type 1 diabetes, and then villus atrophy of the small intestines. And then again, similarly, treatment is that stem cell transplant that is likely curative. The next one we'll go through is autoinflammatory defects such as XIIP deficiency. So in that one, they're unable to clear pathogens, and they have increased cytokines. Symptoms, again, are infantile onset, so very early age, severe colonic and perianal disease, and they are at risk of fatal HLH, especially in the setting of infection, usually an EBV infection, so something to be mindful of with that. And again, the treatment is likely curative with a stem cell transplant. The next one we'll talk about is NEMO. So this is an epithelial barrier function defect. It is X-linked. And then the presentation with that one is infections, hypotonia, poor sweating, thin hair, frontal bossing, poor growth, and diarrhea. So I just wanted to kind of highlight some of the intestinal or some of the monogenic defects that we can see more commonly, although I would say in my practice, being about 10 years at our IBD center, we've only seen like 2 cases of any of these, and we have a population of about 1,000. So not something that you'll come across on a day-to-day basis, but as we've highlighted here, it's important to make the identification of these because it can influence the treatment and prevent, especially a surgery that wouldn't have otherwise needed to happen. And so just another note about vaccines specific to VEO-IBD. So due to starting immunosuppression at such a young age, in discussions with the infectious disease colleagues, they may give suggestions on how to alter the vaccination schedule to make sure that we're giving them all the protections they need. And then here are my references. So just wanted to give a quick update on VEO-IBD and